professor of public health at Southern Illinois University in Carbondale, Illinois. He also holds a joint appointment with the Department of Neurology and the Dale and Deborah Smith Center for Alzheimer's Research and Treatment at the Southern Illinois University School of Medicine. He completed his MBA with Eastern Illinois University, then went on to earn his PhD in health education at Southern Illinois University. His professional interests include military service members and veterans, implementation science, and health geography, and geographic information systems. Justin?
I'm really excited about the opportunity to be here. When Dr. Higgins invited me, it felt like a surreal moment. So I'm excited to be here. I've enjoyed the city. It's beautiful, and had a good time getting to know some of the people who work here at University of Vermont. So I'm going to be talking about women veterans today. And I first just want to say thank you to some of the folks back at SIU who've been working on behavioral economics. We're in the beginnings of kind of forming a team to work on behavioral economic issues, particularly with veterans. And we're really sort of a Stephen Higgins fan club there at SIU, and really have followed your work for a while. So I first kind of want to start out with a big picture and talk about smoking among women veterans. Yesterday, if you remember from a couple of the talks, you saw the men versus women smoking prevalence rate, which was like 13% for men, 10% for women. So in the general population, smoking prevalence is higher for men, but it's the opposite with the veteran population, which is quite interesting. Women veterans smoke at higher rates than men veterans. And some of the most recent research that I could find had a prevalence rate of 28% for men and 28% for females and 21% for men. And that came from data that was about in 2015. And so I went to the population assessment for tobacco and health data set just to try to get some more recent data for this talk. And that's presented in that table there on the left. And you can see even up through 2021, women veterans smoke more than non-veteran women, 16% compared to 11%. And so given this interesting disparity, I felt like it would be worthwhile to spend some time looking at why is it that women veterans smoke more than men, and why they smoke at higher rates than the general population of women. So a shameless plug here. I have my first edited volume coming out in November, where we unpack some of the issues that I think stem from having experience with war. We talk a little bit about what we're calling the invisible wounds of war, essentially the psychological harms of being in combat. And it gets at some of the issues I'm going to speak today about, particularly about moral injury. But there's an effort in the book to try to unpack what the experience of war is like. It's quite extreme. And there's a quote in there from a famous general, something to the effect of, war is hell. You can't qualify war in any harsher terms than I will. War is brutality, and it casts a long shadow. And so we can't understate the brutality of war. Right now, I have a small contract to help Veterans Affairs characterize a new TBI rehab program that they're doing in 5 states in the U.S. And it's kind of a head-to-toe 14-day inpatient rehabilitation program, which includes all kinds of assessments, but they also screen for and then provide treatment about alcohol use, tobacco use. And I've been doing one-on-one interviews with several of the people in this program, most of which are special operations members. but others are just regular active duty service members in it. And I can't forget one interview that I had a couple of months ago with a woman. And just in passing, she said something to the effect of, yeah, I've seen too many of my colleagues just go up in pink mist, and then just kept talking. And I was speechless for a while. And she said, after she got done talking, she's like, "Are you there?" And I'm trying to, pull myself together after having heard her just say this like it was common. So the experience of war is something to consider, especially as we're thinking about the outcomes of it, and smoking in particular. Women got the chance to be involved in the military in 1948 with some legislation that was passed. But you can kind of see from the pamphlet that's up there that women really were just there to support men. They didn't really have much of an active component in the military. But with the global war on terror, finally there was some more legislation passed, not necessarily because of preference, but out of necessity to allow women to have more involvement in the military. And then finally in 2016, there was legislation passed that finally allowed them to choose any occupational specialty in the military, including the traditional boots on the ground concept. And so what have their experiences been like so far? Well, I've got an article cited here, Maddox et al. That was a qualitative study that got lots of really interesting information from women veterans. And there's just high rates of military sexual assault, high rates of combat trauma. And I just wanted to read to you just a couple of short quotes from the participants in that study. This one kind of illustrates the sexual trauma piece. We would drive past male soldiers on base, and they made hand signals for different sexual things that they wanted to do to somebody. And I brought this up to my superiors. I was like, this needs to stop. It's just getting ridiculous. And it went on even worse, and they did nothing. And then another quote kind of highlights the combat trauma piece. This person said, I had the unfortunate experience of having to kill a child, an Iraqi child. Our convoy had broken down, and this kid came running for us. He wouldn't stop, and it was me and my battle buddies or the kid, and they were using kids as bait. And the kid was trying to sell us Coca-Cola soda, but really this kid was wired, so it had to be the kid that was going. And so you can imagine how traumatic these kinds of experiences would be, and you bring these back after your experience in war. And you think, well, there's probably lots of post-traumatic stress disorder. That's the go-to psychological diagnosis, I think, with military veterans. And you can imagine that with women veterans in particular, because of the high rate of sexual trauma and combat trauma, that PTSD prevalence is actually highest in women veterans. But I think that just from the interviews that I've done with these service members that I've talked to you about, there's something deeper going on. There's something that's a little bit even more haunting, you might say, going on in their hearts and minds. And that kind of leads me to this concept called moral injury. I've got one of the most early definitions of the concept there on the slide. Perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And because it does sound similar to PTSD, there's been some efforts in kind of the psychometric type studies to look at in factor analyses, kind of how the different items in these two constructs might load onto their respective construct. And PTSD has very different symptoms. It often manifests in exaggerated startle reflex, memory loss, flashbacks, nightmares, insomnia, whereas moral injury results in guilt, shame, anger, and social alienation. And these items are not loading onto the opposite construct. They're their own. It's its own thing. And that study did show that there was an association between the two, PTSD and moral injury. They might co-occur, but they are distinct constructs. There have been lots of efforts to develop tools to measure moral injury. I've got some of them listed here, just the acronyms. And I think the proliferation of psychometric tools to measure moral injury has kind of complicated its ability to be integrated into the VA disability rating, for example, or to be a DSM diagnosis. And so there's, thinking about this conference, there's not a whole lot of difference, not a whole lot in the literature about the differences between men and women in their experience of moral injury. But one study that I found showed that maybe 37% of veterans report having the experience of moral injury, which is much higher than the report of PTSD. So potentially it's a larger, more extensive problem in this population. So here's just an example of one of the moral injury scales, the moral injury symptom scale, military short form. And you can just see from some of the items that some of the issues being measured include betrayal, perpetration of things that go against your values, the idea of forgiveness, spirituality. It's all included in moral injury. So what are the correlates of moral injury? I've done a little bit of this work myself. I did a study that looked at the association between, and this is just cross-sectional survey research. I looked at the association between moral injury severity and quality of life, and I found that even after adjusting for lots of different covariates like demographics and other socioeconomic variables, moral injury severity was significantly associated with decreased quality of life. And then in another study, I looked at moral injury severity and its association with suicidal behavior and substance use. And similar results were found in that study, where moral injury was associated with increased suicidality and substance use. And although it wasn't the main objective of the paper, I did have the data and was able to look at differences in men and women. And this graph on the bottom left of the slide shows moral injury severity scores on the x-axis and suicidal behavior scores on the y-axis. And then the blue line is for women and the red line's for men. And you can see that as moral injury increased in severity for women, it had a greater impact on their scores on the suicidality scale than it did for men. And so it seems like maybe moral injury impacts women in a greater way than it does men, and that manifests in some of the outcomes that I've talked about here. So like I said earlier, there's not been a whole lot of research trying to understand differences in the experience of moral injury among men and women. But one kind of pilot study that I've done made an effort at trying to understand that a little bit. Me and some colleagues created what we call the moral injury purchase task. It basically borrows from behavioral economic frameworks and asks questions that go something like, for X amount of dollars, $5 per year, how many years of services would you provide if they could, eliminate the thoughts that you have that you carry with you from being in war? And the prices just escalate, and we see how many years of services people will buy at higher prices. And so it gives us an opportunity to find out how sensitive someone might be to the experience of moral injury. And the main objective of that paper really was just to validate the tool, but we did have the data for men and women and looked at those differences. Again, small sample size, so there's a lot of work that needs to be done here, but the Pmax value, which is usually the marker at which consumption becomes elastic, they begin to consume less of the commodity, was much higher for women than it was for men. and their moral injury event scale scores, which is one of those standardized measures of moral injury, also had higher scores for women than men. In an independent samples t-test, the Pmax difference was significant, but the scores on the MIES were not. So it's possible that women veterans potentially have a more difficult time with moral injury than men. So there's been quite a bit of work on moral injury and substance use and suicidality. And when Dr. Higgins invited me to this conference, I got to thinking about tobacco and looked at PubMed and Google Scholar and search terms like moral injury and tobacco use, and just wasn't seeing anything at all. Really, there's nothing. And so because there's a link between a known link between PTSD and smoking, I thought, well, maybe moral injury might have an impact on smoking among women veterans, especially given it seems to be more prevalent than PTSD anyway. So this is, with the time I have left, I kind of want to camp out on this study that I have that's ongoing. Been recruiting some women veterans from a few different places like Amazon MTurk, Reddit, and a nonprofit organization called The Mission Continues, which I've worked with in the past. Like I said, you had inclusion criteria was that you had to identify as a woman, be a veteran, and be a current smoker, person who smokes. And we created an online survey that included the Fagerstrom nicotine scale, the moral injury symptom scale, and then some demographics. And we used, based on what has been done in some other studies, we used a cut point of about 36 to establish that someone would have probable moral injury or someone would not. To get off into the weeds statistically a little bit, we used this Stein et al. Algorithm to detect people who weren't responding in ways that conform to the law of demand. And then we used Kafarnas et al.'s demand model to fit the data. And we calculated some standard demand indices like Q0 and breakpoint. And we also established convergent validity with the Fagerstrom instrument. So the demographics for that study broken down by moral injury severity status shown here. The probable moral injury group is on the right. The unlikely moral injury group is on the left. And they were similar in all the demographics except for length of service. And those were quite different with, to borrow Dr. Levine's comment this morning, if I'm to fudge on the math, it's about twice the length of service in the probable moral injury group. And so we used Kafarnas's model, like I said, to fit the data, and his colleague, blanking on his name now, I knew that this would happen, but his colleague at University of Kentucky created an RStudio package called Be Easy Demand. So I'd be happy. Kaplan, thank you, nailed it. If anyone would like to geek out with me about fitting demand curves using that package, I'd love to talk afterwards. But the data resulted in some demand curves that seem to conform to the law of demand. The panel B there, which is the one I think is most compelling, shows the price per cigarette on the x-axis and the cigarettes purchased on the y-axis. And you can see that if you look at the different curves, the pink one is for the probable moral injury group. The bluish green is the unlikely moral injury group. Their demand for cigarettes was higher than it was for the unlikely moral injury group. We looked at the specific demand indices that might be significantly different. Q0 was one in particular, and you can see that Q0, which is the number of cigarettes someone would buy if they're free. Those purchasing behaviors were significantly different, where the probable moral injury group would purchase 22 cigarettes within a 24-hour period if they were free, whereas the unlikely moral injury group would purchase 13. So you can see that moral injury seems to have some association with intensity of demand for cigarettes among women veterans who smoke. But again, this is a small sample, 44 participants, and so we definitely need to continue to collect data. And then we looked at convergent validity of the cigarette purchase task with the Fagerstrom scores, and those were significantly associated with PMAX and OMAX in both groups, the probable moral injury group and the unlikely moral injury group. Since there's not a whole lot of research in this area, there's a lot of work to be done. It seems that moral injury is a significant issue among women veterans, and potentially it has the ability to predict intensity of demand for cigarette use. And so my group would love to continue to do research on this. I think the next step is to do some longitudinal type work. And I think I'll stop there. That's about all I've got. So thank you very much.
Thank you, Justin. And like with the earlier panels, we're going to have the speakers come up as a group afterwards and do a Q&A. So I lost my place here. Give me a second here. All right, so our next speaker is Eric Threlkill. Eric is an associate professor in departments of psychological science and psychiatry here at the University of Vermont. His work concentrates on how decision-making and instrumental behavior influences risk for substance use disorders, cigarette smoking, overeating, and how such factors connect to fundamental mechanisms of associative learning and behavioral regulation. Dr. Threlkill's current focus is on, one, the relationship between loss aversion, or the tendency for potential losses to have a stronger influence on behavior than equivalent gains, and risk for cigarette smoking and other substance use. Two, understanding the sequential, quote, chained structures of instrumental behavior and how this informs how we make and break habits, whether healthy or not. And three, variables that influence the effectiveness of treatments that involve differential reinforcement. His goal is to improve the understanding of cognitive mechanisms and behavioral processes that underpin durable behavior change. Dr. Threlkill received his PhD from Utah State University and completed his postdoctoral work at the University of Vermont. Eric?
Oh, there it is. Thank you, Steve. It's really a great pleasure to be here. I've really enjoyed all the talks so far, and I've been coming to this conference since 2013, so it's just really nice to be able to be invited to be a speaker and talk about some of the work I've been doing as a member of the Vermont Center on Behavior and Health. So to start, I'll just say that I don't have any conflicts of interest. I'd really like to express my gratitude to Steve Higgins for supporting my work and being a great collaborator on this project, as well as Mike DeSarno, who's provided expert statistical support. I'm funded by the Vermont Center on Behavior and Health and NIDA. So it's been pretty well established at this meeting that behavior influences health. And so like the classic statistic we like to bring up is that over 40% of all deaths each year are attributable to behavior. It might be called the number one cause of death, our behavior. And behavior change, of course, we've been talking about, in particular with cigarette smoking, can have a massive impact on society. And this includes, of course, addressing cigarette smoking, other substance use, overeating, sedentary lifestyle, non-adherence to medical information, so forth. And of course, as we've seen, there's lots of progress being made in several areas, and especially being made to address marginalized and vulnerable populations. But of course, there's much to do. So as a little bit of a departure from what we've been talking about, I want to sort of focus on the processes that might be involved in behavior change, right? So the role of rewarding events in people's lives plays a very important factor in influencing whether they use drugs or don't use drugs, right? So we know from contingency management is that if you increase the sources of non-drug rewards in people's environments, you can decrease drug use. That's the principle that guides the idea behind contingency management and the community reinforcement approach. We also know that these types of behaviors that you engage in that are detrimental to your health can result in lost access to reinforcers in our lives. It could be in the shape of lost opportunities, relationships, or lost well-being in the long run. So I'm going to talk about the psychology of losses. So I'm interested in this process called loss aversion, which states that the expected and experienced losses that we have in our lives tend to have a stronger influence on our behavior than what would be experienced when we receive equivalent gains. So to illustrate this, one example has always been the endowment effect, right? So in these experiments, if you give people, say half of the people in this room, a coffee mug and a piece of paper, and then the rest of the people just a piece of paper, and you ask each person to write down how much they would, the people who have the coffee mug, how much they would be willing to accept to give it up, and the people who don't have the coffee mug, how much they'd be willing to pay to get or obtain the coffee mug. You'd see that on average, the people who had the coffee mug would be asking about twice as much for the coffee mug than the people who would be willing to pay for it who didn't have it to begin with, right? So you would ask about twice as much to give something up than you would otherwise pay to get it. And so that's called the endowment effect. That's an example of loss aversion. Other examples of it in the psychological literature has been called the negativity bias, or bad is having a stronger effect than good. And these ideas have been the foundational principle in prospect theory, and how prospect theory characterizes value in behavioral economics. And this work, of course, is very influential and has led to several Nobel Prizes. However, it hasn't really been integrated into understanding how our behavior relates to health. So my working hypothesis for this project is that loss aversion can be a protective factor, can keep us from engaging in behavior that's detrimental to our health. And so there is some literature out there that has investigated loss aversion in people that use substances. Okay, so some of this work has been done with individuals in outpatient treatment for alcohol use disorder, right? And so they've shown that there's decreased sensitivity to losses in certain tasks that arrange experience with losses, such as the Iowa gambling task and other gambling tasks. They've also shown that individuals who are alcohol dependent, who have received fMRI scans and show there's cortical atrophy that's associated with low loss aversion, independent of other executive function deficits. It's also been observed in individuals who use cocaine. There's lower loss aversion in certain tasks that measure it, as well as in populations that are using several substances. So there's low loss aversion at time one, longitudinally predicted more severity of substance use at time two, a year later. And so the question is, can loss aversion be distinguished from other important variables that are associated with health impacting decision making, such as delayed discounting? So delayed discounting describes how reinforcers or rewards in our environment lose value as delay to their receipt increases. And it's been found since the 90s, early on, that the value of future rewards is lost much faster in individuals that are using harmful substances such as cigarettes and heroin compared to others that are matched to them demographically. Okay? There's also been shown a longitudinal association between steep loss of that reward value or high delay discounting and uptake of regular cigarette smoking among adolescents. And so delayed discounting represents a decision-making variable that's pretty well established as being a predictor of substance use and other harmful behaviors in several different settings. So I'm looking to understand loss aversion kind of in a similar way. It's much less understood, but it might also be a very important variable. And these previous studies that have examined loss aversion in the context of substance use haven't accounted for delayed discounting in them, and so delayed discounting could be explain those differences they've seen in loss aversion so far. And these other studies haven't accounted for the role of cigarette smoking at this point. So cigarette smoking is also highly comorbid, of course, with these other substance use problems, as we've seen so far. And so the studies that I'm going to talk about have attempted to address this issue, to understand loss aversion and its role more deeply. Okay, so the first one I would like to talk about asked a few questions about loss aversion and risk for cigarette smoking. First is low loss aversion associated with increased risk for cigarette smoking? And are low loss aversion and high delay discounting independently related to cigarette smoking risk? And how does loss aversion and delay discounting perhaps combine together as behavioral risk factors that will accumulate and influence and lead to greater risk for cigarette smoking as well as other substance use? So we collected data from Amazon Mechanical Turk. These individuals reported current daily cigarette smoking of more than 10 cigarettes per day. And another group reported never smoking status, which is less than 100 cigarettes smoked lifetime. They're also matched on age, gender, and educational attainment. And we measured loss aversion using a hypothetical gamble task where we posed a coin toss scenario to people, right? So we received trials where they'd be asked would they accept or reject this gamble, and it'd be a potential loss and potential win. All right, so here the loss is $6 and the win is $60, and they asked, would you accept or reject the gamble? And so this one looks pretty attractive. You'd probably say I would accept it. In other trials, though, it got a little bit more difficult, right? The gamble gets less attractive, right? So now the win is $32, but if it comes up the other direction, you have to give me $31. So you probably wouldn't want to do that. And this one is especially unattractive. So you get $2 if it came up your way, and you have to give up $31 if it came up the other way. So definitely wouldn't accept this one. But this type of task has been used to measure loss aversion in several settings, in person, online, fMRI, that sort of thing. And it's also been used in some of these previous studies on substance use and loss aversion. So we used it in this way online. So we gave people blocks of 49 trials of sort of experimental details. We give them different conditions where they're varying the amounts of the loss and the gain very thoroughly to collect lots of data. And so it sort of would look like this. This is an example of all the different trials that they would be getting. So we have loss amount on the y-axis and gain amount on the x-axis. Here the gains are twice as large as the losses, and you get each combination of them. So if they, in this case, if the value of, you can illustrate loss aversion in this way too. So if the value of the loss is equal to the value of the gain, meaning there's no loss aversion, then you expect them to accept every gamble where the value of the loss is larger than the value of the gain, right? But if the value of the loss is greater than the value of the gain, meaning they are loss averse, you should accept about half, right? So in this case, right? So some of them should be a toss up when the value of the loss is equal to the value of the gain. Sorry, the value of the gain is equal to twice the amount of the value of the loss. But in other scenarios, you should accept far fewer in this case, about 50%. Right? So the gain amount is twice as large as the loss amount. You should accept about half the gambles. Okay. We also measured delay discounting in this task with the same monetary choice questionnaire that's been studied in many studies, cited thousands of times, very standard delay discounting task. We included this as a control variable, right? We wanted to assess the effect of loss aversion and delay discounting. So here's what the demographics look like for this study. We tried our best to match on gender and educational attainment through stratification. And it sort of ended up looking like this. Is similar to what we've collected for most of the other studies I'm going to talk about. Around 200 participants per group, smoking and never smoking. The data ends up kind of looking like this. You can plot it like this, and this is sort of a heat map type of way. We had two conditions where on the top, the gains were twice as large as the losses. On the bottom, the losses twice as large as the gains, except far fewer when the losses are higher, of course. And they accept more as shaded by lighter colors in the smoking group than the never smoking group. The darker color means they rejected more. You can also represent this as simple bar graphs, of course. And so on the left here, we have the 2-to-1 gains condition. And what you can see is that the individuals in the smoking group who reported current smoking accept more gambles, right? It means they're less loss averse than the individuals that reported never smoking. That right panel there is showing their delay discounting rates. And here we replicate previous findings, showing the individuals in the smoking group more steeply discounted the future than those in the never smoking group. So we replicate both those effects. We then could do, and that's kind of a sanity check. We can do then comparisons. We also ask people about their other substance use, alcohol use, other drug use, and we can look at the comparisons between those in the sample that reported different combinations of substance use as well. So here's a sort of busy table showing that. We have models then looking at the difference between those that reported cigarette smoking, alcohol use, other drug use, and then the combinations of those. And then we had a couple other control measures, depressed mood, sleep disturbance in there. And then we have here models with differences shown between gambles accepted in these groups when loss aversion is assessed and delay discounting is assessed separately in separate models, and then models where we have loss aversion controlling for delay discounting and delay discounting controlling for loss aversion. And this suggests that loss aversions, the difference in loss aversion remains significant when controlling for delay discount, right? So they're not explaining each other. They're not knocking each other out of these models. We can also then look at, okay, turning the predictors around, how do loss aversion and delay discounting predict substance use, right? So if there's lower loss aversion on the measure, you're sort of at the ends of the scale of accepting or rejecting gambles. How does being more extreme in loss aversion predict your likelihood of saying that you are currently smoking cigarettes? You can see that lower loss aversion, meaning that greater gambles accepted, is positively associated with likelihood of saying you smoke cigarettes, you use alcohol, other drugs, and then do the combinations of use, right? In the same model, delay discounting is also a significant predictor of smoking and other drug use. So they're independent predictors, right? There are a couple, though, shown at the bottom, interactions going on there, right? And so there might be the case that having one of them increases the likelihood of having of smoking, but having both of them might increase the likelihood of smoking further, right? So we looked at that, right? So what I'm highlighting here is that the effective loss aversion among the individuals who had the highest level of delayed discount. Okay, and so among those, there are a couple situations, especially with drug use, that having low loss aversion, even when you already have high delay discounting, further increases your risk of having these substances, especially with drug use, smoking and other drug use, and all three in alcohol and drug use. Further explaining the interaction, if you already have low loss aversion, adding steep delay discounting on top of that doesn't further increase your risk for using drugs. Okay, so to summarize this study, low loss aversion was associated with cigarette smoking, alcohol use, other drug use, and polysubstance use. It was not accounted for by delay discounting in the same individuals, or accounted for by sociodemographic factors, age, gender, and educational attainment, which we included in all of these analyses as covariates. And so, like high or steep delay discounting, low loss aversion can be associated with unhealthy behavior. Right? So we sought out to examine this further by doing a full replication of this study and adding another behavioral variable that is important. And so I mentioned that the relative density of drug and non-drug rewards is important for determining, for influencing risk for addiction. We sought out a measure of environmental reward density in these people's environments. And so one example of this would be the pleasant events schedule, which has many, many items and take a long time to do online. It wouldn't be possible. But it has been shown that low density of non-drug rewards is present in individuals who are using substances. So cocaine users had a low density of non-drug rewards measured in the pleasant event schedule in comparison to non-users. And individuals that abstained from cocaine use successfully in a contingency management treatment also tend to have greater reward density as measured with the pleasant event scale. So this does suggest that there is a relationship there between risk for substance use and environmental reward density. So we found one measure of this out there called the Reward Probability Index, which was only 20 items and had been associated with alcohol problem severity in college samples. So we collected another 400 participant sample of people who smoke cigarettes and then people that report never smoking cigarettes, and it examined loss aversion, delay discounting, and now this reward probability index. And I'll skip to the good part with this one. And so here what I'm highlighting is sort of a manipulation check, right? So at the top there, we have the reward probability index. And what that's showing is that lower scores on the reward probability index are associated with greater depressed mood in our sample. And this measure was developed as a measure of depressed mood. And so this is telling us that it's measuring what we expect it to measure. We're also seeing that it's also lower environmental reward is associated with greater risk for cigarette smoking, which suggests that it's a predictor. And also below that, we're showing that higher delay discounting rates are associated with higher levels of cigarette smoking, as well as greater proportion of gambles accepted or lower loss aversion. And so when these are all in the same model together, they're all independent predictors of smoking and other substance use. Okay. And so again, loss aversion isn't accounted for by these other variables. And what's kind of neat about this is that you can look at, okay, well, out of all three of them, do they sort of stack on top of each other, right? So we separated the groups on high and low levels, defined as greater than or less than one standard deviation. And we asked whether low loss aversion, high delay discounting, and low environmental and reward density influence risk in combinations, right? So down here, we have increments of one being shown. So having one versus having zero of them at the very bottom increases risk for smoking. And it doesn't matter which one. But then going from having 1 to having 2 increases risk more than 2. Going from having 3 having 2 increases risk for smoking, the top there, more than having 2. But also we can look at, okay, what about increments of 2, having 2 versus 1 or 3 versus 1 of these, and it doesn't matter which one, that results in an even greater increase in risk. And then of course the whopper is having 3 versus 0. If you have all of these, it really sort of increases your odds of smoking by sort of 12 times. And so these seem to sort of stack on top of each other in terms of contributing to risk for unhealthy behavior. Okay. So one classic study on delayed discounting assessed whether delayed discounting differed by smoking status, right? So they looked at individuals who had been smokers and had quit. So we collected a third study here where we have groups of 300 people who had reported never smoking status, current smoking status, and former smoking status. And we assessed loss aversion and delayed discounting. And what this is showing is that in terms of the gambles accepted, the most are accepted by the individuals that currently smoke cigarettes. So they're the lowest level of loss aversion. And then the never smoking and former smoking groups tend to be more similar to each other. They accept fewer gambles. They're more loss averse. And at the bottom, we have delayed discounting. And there, the former smoking and never smoking groups are similar to each other, just like I had shown previously in the original paper. And the people who are currently smoking are discounting delayed rewards more steeply. So we're here showing that you get a similar pattern of results with former smoking status with low loss aversion than you do with steep delayed discount. And so in these comparisons, we are accounting for loss aversion and delayed discounting in each model and showing that they don't explain each other either in this case. And so this raises some familiar questions, right? So does quitting smoking cigarettes result in an increase in your loss aversion? Or does having higher loss aversion to begin with predict or allow one to quit smoking in the first place? The same questions were asked about delayed discounting, and that's why they did the longitudinal study on it, but that hasn't been done with loss aversion. Okay. So we have all this data, and we're interested in, of course, demographic differences. We had been including different demographics of age, gender, and educational attainment all along as covariates in our analyses, but of course we wanted to see whether loss aversion and its association with cigarette smoking risk may differ across levels of demographic characteristics, because they're of course related to smoking, as we've been talking about, of course, this entire time. So we have a sample here, another one from MTurk, where we looked at risk or loss aversion's association with risk for smoking in this case. And so now we see that across levels, all the dots are past the dotted line for the most part, except for income. But from the top, age and gender, male and female participants are also greater loss aversion associated with, lower loss aversion is associated with greater risk for cigarette smoking, very consistently across levels of the demographic characteristics. And so we don't really see a difference between the relationship of loss aversion with smoking based on gender. So in this sample, right? So there's a very consistent relationship with the exception of income down there, which is itself very interesting. I'd like to explore further. Right, so in having all this data, we wanted to look a little bit more in depth at how loss aversion and delayed discounting might combine to influence risk. And so we think that maybe there could be risk factor profiles going on. So we asked whether the presence or absence of low or high delayed discounting influence risk differently, right? So here I'm showing another forest plot where we have plotted either having low loss aversion or high delayed discounting versus having neither, and then having both of them, low loss aversion and high delayed discounting at the same time versus neither. And so at the very top there, we're showing risk for smoking, and having one of them doubles risk for smoking in this population. But having both of them at the same time in comparison to neither increases risk even further, right, on top of that. And that pattern appears pretty consistent across all the other substance use patterns that we've measured in this group, right? So compared to having neither, having one or both increased risk for substance use. Well, what about having just one of them, right? So here we're showing in comparison to having just delay discounting or just low loss aversion, how does having both low loss aversion and high delay discounting further increase risk for smoking and other drug use and so forth? So the co-occurrence of both of these together is increasing the odds of smoking by about 2. Right, so they seem to both work together to increase risk relative to just having one of them. Well, here's another question. Well, does having low loss aversion increase your odds of just having high delay discounting itself, right? So, or vice versa? Does having one predict having the other? Are these sort of clustering risk factors? And it appears the answer is yes, that having one, so the likelihood of having low loss aversion, given that you have steep delay discounting, is about 2, so increase about twice the odds. And then the vice versa is also true here. If you have high delay discounting, you're twice as likely to have low loss aversion as well. So they tend to sort of cluster together here. Having the presence of one is predicting the presence of the other. And so they seem to go together in the sample. And so finally, I wanted to look at these data in a little bit more depth, right? So might low loss aversion influence risk differently in women? Now, there is a literature on there suggesting that in general, women's loss aversion is higher than men's loss aversion, but there isn't any evidence out there suggesting that puts them or influences their risk for smoking and other substance use. So here we're looking at odds ratios with models with loss aversion and delay discounting and education and age included. And we're seeing that there's really not much of a difference between the risk for smoking, other drug use, and so forth between men and women when you have low loss aversion. Right? So it increases risk for smoking, other drugs, and other substances similarly for men and women. So across this large sample, so this is a sample of 1,800 people now. So overall, I'm trying to get across the idea that low loss aversion in behavior is related to substance use risk, and it might be distinct from high delay discounting and other important variables related to substance use, like environmental reward and sociodemographics. But there's a lot more to do on this, right? So I mentioned that not much is known relative to delay discounting. We need to do a much more finer grained analysis of severity of use, subpopulations, and other at-risk demographics. We need to understand how general the relationship is. Low loss aversion contribute to risk other problem behaviors. We look at this in more national representative samples, different populations, and assess its stability over time. Ultimately, I'm really interested in understanding this causal relationship. Doing a longitudinal study would be great. So understanding what contributes to low loss aversion, whether it's malleable, and if it's malleable, does that translate into changes in actual behavior? Can it be a prevention or intervention target? Are all questions I'm interested in addressing. I'm also interested in just telling us, well, what does loss aversion actually telling us about the reinforcement process that's going on? Often when we talk about variables that influence behavior, we talk about the events that do occur to people, but we're seeing here that there's often an influence of events that don't occur, right? And so are we sort of getting at individual differences in expectation violation that might be going on? Are they less sensitive to reinforcers not happening in their environment? Is there differences in sensitivity to relative value? Do losses mean less to people in different contexts? Is this influenced by substance use? And how does these effects accumulate within people? Are all sort of open questions that this is bringing up. So that's all I have. And so I'd like to thank again my collaborators, and thank you very much for the invitation, for being here. And I can answer questions.
So we have plenty of time for questions, if there are any.
Hi there. Thank you very much for your talks. Really awesome stuff. I have a question for Dr. McDaniel. I was wondering, so did everyone, I'm sorry if I missed this information. It's a really interesting concept that I was trying to kind of get everything in. But I was wondering, did everyone in your sample have some kind of eliciting event that would be like traced back to the moral injury? Was that like part of your exclusion criteria? And I have a follow-up question after that.
The more I think about the study, the more I feel like that's a major limitation. We didn't even assess for whether someone had been deployed in combat or not. And so I would imagine the moral injury scores would be night and day different for those who've been in combat and those who haven't, but we didn't ask about it.
Yep. Okay, thanks. And then my follow-up question is, so when there is an eliciting event and no moral injury, and you still have low moral injury, what do you think might help explain like resilience to developing moral injury?
That's a good question. Yeah, I don't know what the answer to that would be, but I know that there's been a little bit of work on moral injury prevention. It kind of parallels the work that's been done in psychological resilience training. I think similar concepts have been borrowed for that. To my knowledge, that's not very widespread and certainly isn't a part of like basic training or anything. So I'm not quite sure at this point what would explain an eliciting event not causing moral injury. Good question. Yeah.
Thank you both for wonderful presentations and discussions. This question is for Professor McDaniel. What mechanism do you think is driving the relationship between moral injury and increased tobacco demand? Is it like a self-medication type thing, or I guess what, if you had to take a guess, what would it be?
Well, the VA has not acknowledged moral injury as a psychological construct to be treated. And so because they're not treating the root cause perhaps of the issues, yeah, self-medication is the issue. They look to cigarettes and other substances. Yeah.
Thanks.
Question for Eric. I was thinking about those concepts of loss aversion, and have you looked at, or I know a lot of times impulsivity is also factored in. Has that been looked at, or have you found good reason to not look at that?
Great question. Yes, I have looked at 3 of the major impulsivity measures, like the Barrett Impulsiveness Scale and the SUPS-P, and there's another one, the Behavioral Inhibition Activation Scale. And so I've assessed those in the same way. So in models with loss aversion and delay discounting in there, and they all remain significant predictors of cigarette smoking too. Like, so they don't explain each other either, which is really interesting because, well, delay discounting is sort of oftentimes described as measuring impulsivity itself. But it seems to be capturing something that's separate from these other things. And in some of them, delay just kind of gets knocked out of the model or weakened. The loss aversion is always remaining as significant as it usually is. So it might not be, it might be independent from impulsivity as a construct.
I had one additional question. I was looking at the ages that you were able to capture information on, and I was interested in the adolescent mind, especially as far as thinking like risk aversion and those kinds of things that are still developing, and what that would look like maybe if you were able to capture that information in the future.
Yeah, I'm definitely interested in that, especially in the context of doing like a more longitudinal study of like trying to catch people before they start using substances. And there's not a lot out there studying loss aversion developmentally. There's maybe one or one study I could think of right now. So they use the type of task that I'm using here with adults, and so it's definitely very much of interest to me. But I don't really know whether it's sort of heightened at a certain developmental phase in comparison to later on, like it matures or something like that. It's really not well studied.
Questions, comments?
So for Dr. McDaniel, and I'm interested in the concept of moral injury in your study with veterans, but I'm wondering if you are aware of anyone studying moral injury in other groups that we know that are at risk, for example, healthcare workers, right, who are currently especially undergoing lots of moral injury, kind of moral dilemmas. And in my experience, there are a lot of nurses that smoke, and we all know better. So where is that coming from? Do you know of anyone?
Yeah, there's a parallel literature with healthcare professionals, along with the military. In my study, I used the moral injury symptom scale for the military, but there's also a moral injury symptom scale healthcare professionals, MISSHP, and I saw a lot of that blossom during the pandemic, and so there's certainly a lot of work with healthcare professionals, but outside of military and healthcare, I don't know if it's been applied elsewhere. Yeah.
I have a question for Justin. Have you had a chance to meet Kelly Peck here? We have a PTSD expert within the DCBH. So I don't know if you had a chance to meet him during this conference. So that would be a helpful thing, I think, potentially for both of you to be able to talk to each other and work on this topic together. Has anybody tried to teach more or treat moral injury with exposure therapy like you treat PTSD?
Well, I've been trying to make my rounds today with some of the folks. Kelly, if you're here, I'd be happy to.
I don't see him here, and that's what we should try and avoid, to make sure you two are talking and listening to each other. But yeah, during the noon hour, he gave there were 3 speakers, and he gave a 15-minute presentation. I tell you the truth, it was more on what they're doing in the Center for Rural Addiction than his PTSD work, but it was mentioned in it. Anyhow, I think it would be helpful for the two of you. So then what about anything in the literature about treating moral injury with the same therapy that you would use, at least the evidence-based therapy that you would use for PTSD?
Sure. I've not done any treatment work myself, but I have read papers about moral injury treatment, and yeah, a lot of it borrows from the PTSD work. Yeah. I've seen cognitive behavioral therapy as well, and I think currently the recommended approach is to combine something like that with a chaplain related service, like the VA has. The VA and the DoD has employees that are chaplains, and so oftentimes those are coupled with whatever psychological services are offered. Yes.
Mark,
quick comment about that one. Cognitive processing therapy might be a useful approach for that one to deal with kind of the cognitions that are related to the moral injury above and beyond just the bad memories of the event per se. But I actually have a question for Dr. Threlkill. You painted a very convincing picture that loss aversion is an independent predictor above and beyond some of the other more well-studied ones like delayed discounting. When I started thinking about this, I have a question that I want to run by you, which is it possible that loss aversion can be a double-edged sword in that once somebody who has been abusing a substance has that as part of their behavior or kind of reinforcement repertoire, they're then averse to give that one up, and it serves as a barrier towards cessation.
Right. So the question you're sort of getting to the idea of domain specificity or sort of reinforcer specificity, right? So you can be loss averse. So I'm asking people about money in this task. It's pretty general, sort of generalized reward in our environment, but it might be different when it comes to just the focus on the substance, right? So I might be very loss averse to giving up cigarettes, and that'd be sort of like a different sort of measure of it. And so I would definitely expect it to be different according to different rewards, right? But even those might be situationally specific too, right? So if you ask somebody whether they're in a high period of deprivation or withdrawal about something, they might be even more loss averse than if they're satiated on a particular substance or something like that. If you're asking about a particular commodity, right? So yeah, there's a lot to learn. Like there's not much done on it. In particular, like there's the study with cocaine did ask people about different amounts of cocaine in the loss aversion task, and sort of showed that they were loss averse about their cocaine, in a similar way they were loss averse about money. From what I recall. Yeah, so it's a very interesting question. Lots to do.
It would seem, Sully, please.
Sort of a follow-up question, actually, Eric. I feel like I should know this because I actually think I reviewed this article in training seminar. So sorry if I missed this. But like so in your analyses, you had a group of people who had low loss aversion versus sort of just like regular loss aversion. Like is there a group, another group that was like extreme loss aversion? And if there was that group, how was that associated with outcomes?
Well, for the high and low in those analyses, we were taking the above and below one standard deviation. So the the high loss aversion group would include everybody who was extreme, and then the low loss aversion group include all the people who are extreme at the other end. Right? So that's what we're comparing is influencing risk. So we've done a number of different ways to get like median split, that type of analysis as well. Same result, but reviewers like the standard deviation. Question.
Other questions, comments? No, maybe any further comments either of you want to make? Yeah. Oh, good. Yeah, from our remote audience.
Yep. We have a question for Justin McDaniel. I've never smoked. For those in the service who have experienced PTSD or moral injury, how do cigarettes act to mitigate bad feelings?
That's the idea of self-medication, essentially. Yeah, I think many people use cigarettes to reduce anxiety and stress, particularly post-traumatic stress disorder. But cigarettes are ingrained in military culture, and so it just kind of becomes a way of life. I think I've read qualitative studies about how it's a way to socialize, it's a way to kill time. So it just kind of becomes habit out of that, and it continues into your retirement. So I think it is a way to reduce stress and anxiety, but it's also just kind of trained in them during their time in the military.
Can I ask a question, Justin? So if you have PTSD, are you more likely to have moral injury, or is it you have one, do you have the other? I mean, because the idea of alleviating anxiety, I think what you were showing is PTSD has the more physiological anxiety type symptoms to it, whereas moral injury is more distinct from that with different symptoms. But
guilt, shame, anger.
Or are they both? But smoking's prevalent in both, right? So do they happen together a lot? Or,
well, the slide that I had up there showing some of the psychometric work that's been done between PTSD and moral injury, I think the correlation was like 0.63 between PTSD and moral injury. So yeah, strong. Yeah, in social sciences, that's pretty strong correlation, but they also showed their distinct constructs as well in factor analysis. So
I can't, well, the 0.63 correlation doesn't surprise me. I don't, and you have the evidence that they load on to different factors. So yeah, I just see for a really promising area of investigation. Definitely in the military, but was that pointed out by our audience, not unique to the military, and you already mentioned you're aware of that in healthcare providers, and just maybe, I'm not sure you need encouragement, but in my career, I can remember being a little dismissive about PTSD and whether its relationship to risk for substance use was a real thing, and trying, instead of people just trying to continue to push self-medication as an explanation for drug use. So when you're trying to introduce the new construct, loss aversion in the face of delayed discounting and moral injury in the face of PTSD, you have to be resilient as an investigator because you're inclined to get some pushback, I think. But I thought both of you gave very compelling presentations, and it's exciting, and yeah, hope you continue pursuing it. Any other thoughts, comments before we close session 5? Okay, well, thanks, guys.
Thanks for having us.
Thank you. And adjourn, and this is the close of the 11th conference, and the prior 10, when I get to the end, I don't really have any great integrating comments or whatnot. I'm as blown away as all of you. I think it's been a tremendously informative conference. I am really thankful to our presenters, the oral presenters and the poster presenters, for bringing such really a diverse range of different studies and perspectives on this common theme. You definitely have taken up my challenge at the beginning of my 5 reasons that I threw out off the top of my head of why we might want to focus a conference on cigarette smoking and tobacco use in women and girls. And you've added on, I don't know what the number would be, but it'd be a lot higher than 5. So that's been really fun. I know I have learned a lot, and I mean that sincerely. And I came into it thinking I knew a fair amount, but that's the wonderful thing about getting a group of folks together, an audience like this. So I leave feeling 2 things. One, enriched, I know more, and energized. And I think the need for doing more to protect women and girls from cigarette smoke. I had cigarette smoking and tobacco use in the title and in the symposium, because I think it would be naive to not do so. But I still think the big villain, the big challenge is cigarette smoking. It's still, only because we grew up in it, doing not just, fall down in wonderment, like the massive killing and unnecessary deaths associated with cigarette smoking. Like, Mark Levine mentioned how, and I think I mentioned at some point in this conference, how Eli Klemper and I tried to get our medical center to do the automated referral. And they do a great job of asking people if they smoke, but less than a great job of doing anything about it for those who do smoke. And we eventually, it took about 6 months of wasted time, postponed meetings and whatnot, till they finally said, no, we're not doing this. And not soon after saying no, they essentially like shut down all the main services in the hospital during COVID in the whole medical center. And they were going to prioritize, and you all lived through it in your own medical centers. And the death rate from COVID that year was less than cigarette smoking in this country. So, you understand it, but you also have an opportunity to just think, boy, we've all grown up, like in my family and my age, smoking was still pretty normative when I was a kid. I grew up with parents and aunts and uncles who just smoked all around us. I remember having chronic bronchitis, and now I know why I had it. But my mom, I think it was from the measles. At the measles, you started, and it was just so normative. And then when relatives died from smoking-related illnesses, you never said, "Oh, Aunt Mary died because she smoked." You said, "Aunt Mary had a heart attack. It's so sad that she went early," or whatever. So I think we're desensitized by just the terrible and devastating impacts of cigarette smoking. And so I don't know if my words there, this is sensitize us any, but I think you all kind of share that view. So I say to myself in these meetings and whatnot, do not take your eye off the ball, that cigarette smoking is the one we have to really do better on in protecting women and girls, while not being naive enough to stop looking at the new guy on the block, which could potentially be worse than cigarette smoking. But that's a tough thing to accomplish, to be worse than cigarette smoking. So what else I think that's about all I have to offer in the way of the audience are both our remote and our in-place, in-person audience. Without the audience, it wouldn't be a conference. So you guys have been great. The questions have really been good. They extended the most recent example of asking a question about moral injury among healthcare providers. I would have never thought of that. Not that I know much about moral injury. I'm just learning from Justin, but it's those kinds of questions, that kind of probing, and it's gone on all both days throughout the day. So that's been wonderful. So then the last thing I wanted to say, well, does anybody else want to have anything you want to particularly point out? I want to give, all right. Then I want to mention each time we do one of these conferences, we follow up with a special issue of preventive medicine. So each of the invited speakers will be and receive an invitation shortly to submit a manuscript based on your presentation topic-wise, but it's not expected that you're going to not deviate at all. That we're all experienced enough to know that naturally happens, and it's not you're not expected or obligated, maybe is the better term, to agree to submit a paper just because you did the conference, but I hope you'll give it serious consideration. And I think with that, I'm just going to wrap up again with another thank you, especially to everyone who's been willing to hang out to the very end with us. So thanks a bunch. Give yourself a go.